All right, everybody. Welcome to your next to last day for ISHLT. I'm Dr. Shelley Hall from Baylor, Dallas, and I'll be moderating your session today, which is Outsmarting the Heart, Device Therapy Targeting the Neurohormonal Pathways in HFrEF. I sound a little bit like a frog, so I apologize. We're going to get started with Dr. Raval from Baycare Health. He's going to lay the groundwork for this therapy.
Okay. So, before we start, I'll tell you that this is a little bit of a labor of love for me because I've really been involved with this therapy since December 2011 when the CEO actually came to me and talked about this conceptually. So it's nice to see it helping people in a market-approved way. But, looking at this screen here, you've seen this before, right? I mean, this is something that we know, and, we do a tremendously good job here in the early stage, getting people on GDMT, leveraging devices appropriately, including, CRT and ICDs. And so I think, there's always some improvement that can happen there per se, but honestly, I think we do a pretty good job, and this is not controversial whatsoever. If you go to the other end of the spectrum down here at advanced heart failure therapies, again, we can probably do a little bit better job as to, when do we kind of make a referral for advanced heart failure therapies. I think that's definitely true, and you can see the I need help, moniker there, and of course, VAD transplant and hospice still have a role at this end of the spectrum. But this whole middle section here becomes sort of this unmet need, and I think I'd like to try and bring that to your attention today. And we need to think about when do we try and leverage what I'll call small devices like Barostim. But if patients persist in having symptoms despite GDMT, what can we do? So quick pathophysiology, I won't get too deep in this, but some kind of insult occurs to the heart, right? And you have decreased contractility. And what that does is really reduce the stretch of the baroreceptors. And that, reduction in stretch of the baroreceptors really tells the brain, hey, I'm not getting enough blood. The brain, greedy organ that it is for oxygen, nutrients, et cetera, really starts to do things like decrease the parasympathetic activity, increase the sympathetic activity, and of course the renin-angiotensin-aldosterone system is activated, and we all know that pretty well. Now, when you have this activation of the RAS system and the imbalance of the parasympathetic-sympathetic system, you get obviously excess in these things, and you have organ toxicity, and you can see what happens here. Obviously, in the vasculature, the kidneys and the heart, for example. I love just talking about the kidneys because the JG cells are innervated by parasympathetic fibers, and one of the things that happens is in the JG cells is you start producing renin. Right, and then we know what that brings down the line. But it suffices to say the cardiovascular function gets worse, and heart failure symptoms then ensue. And of course, we get a kind of a downward spiral with progression. So neurohormonal blockade is clearly not controversial. It's the basis for GDMT. It needs to be so. It needs to absolutely be the foundation of what we do. The problem is that GDMT sort of falls short in some areas, right? So if you look at exercise capacity here with GDMT, you can see, bang for your buck, you're probably going to get more, ability to do exercise with an MRA, interestingly enough. But, it wasn't until we started doing some of the CRT trials that we found that, hey, that we can actually increase exercise capacity, potentially, beyond what we see with GDMT. So, what I'll take a second here and tell you that, what we see with heart failure patients is really two sides of a coin, right? So we have the ability to improve their morbidity and mortality, and I think GDMT does a great job with that. But the other side of the coin is that how are our patients actually feeling? Right, and that becomes important here, and then this illustrates it nicely. A lot of these patients have mobility problems. Daily activities are difficult for them. They have pain or discomfort, and then the anxiety, depression that people may suffer as part of their heart failure is there. What's really interesting is that patients, if you ask them, "Hey, do you want to live longer, or do you want to live with some better quality of life?" 2/3 of people will actually choose a little shorter life for better symptoms and better symptom control. And so I think that's something that really it really should inform us as to what we're doing as physicians here, and keep in mind that, hey, these, again, two sides of the coin. Let's improve their morbidity and mortality, but let's see if we can try and improve their symptoms as well. So in summary here, obviously you see that GDMT really does, again, not controversial, improve mortality, but again, there's an unmet need. CRT does work for patients, but only about 30% of patients are really candidates for CRT, and only about a little over 15% have a class 1 indication where you get the best benefit with CRT. So, there's definitely an unmet need, and I think this is where the small devices like Barostim have a role. So going back here just a little bit, what happens if we stimulate baroreceptors, right? And this is obviously the basis for the improvement in the heart failure that we see with Barostim. And so we interrupt this downward spiral that we have in heart failure, and we'll talk about that further. Again, varied audience here. Some of you may have seen this. Some of you may not have seen this. The pulse generator is about the size of a dual lead ICD. It's not as big as a dual lead pacemaker, I should say, not ICD. Apologies. And so it's a relatively small device than an ICD that you'd see. And this lead is a very, very thin lead that it is, again, extravascular, attached to the adventitia of the carotid bifurcation. And one of our speakers is going to speak more about that today. So let's go to some quick clinical evidence as well. We can see this is the design for the BeAT-HF trial, the pivotal trial for the device. You can see the patients were EF less than 35%, NT-proBNP less than 1,600, no class 1 indication for CRT at that time, of course, and had to have a heart failure hospitalization or an NT-proBNP of 400. Just a quick aside on the BNP. I think what I would take away from that, or why I take away from that, is that this is a bit of an upstream device, right? This is not sort of a device that if you're class 4 and you're kind of on the other end of the spectrum, and you remember my first slide, this is not sort of a bailout kind of situation. So we want to make sure that the right patients are treated. Now, if you look, obviously patients were randomized to medical management and Barostim with medical management. And at 6 months, of course, we saw a good safety profile, improvement of 6-month symptoms, and a reduction in NT-proBNP at 6 months. Nice hard endpoint, can't fake a BNP. And then obviously post-marketing phase, we see a continued improvement in safety and symptoms at 6, 12, and 24 months now. And then all-cause death, LVAD or transplant is reduced. And, remember, this trial was right during the COVID pandemic and really suffered from that a bit. And, again, we saw a neutral effect on CV death and heart failure hospitalization. So if you unpack this a little bit more, all right, the way to read this, by the way, the dark blue is Barostim, control is the light blue, and then the difference between the two is the gray bars. You can see, obviously, that at 6 and 12 months, the Barostim group is, well higher than our control group, and it's sustained at 12 months, right? And again, if you look at 47, 41, clinically meaningful might be 25 meters. That might be, the way somebody might walk into a grocery store or something like that. They're able to do those kinds of things. They can walk a little bit farther, et cetera. So if you look at the little inset on the right, okay, you see Contact, CD, and Miracle. And so, I guess I'm starting to date myself a little bit, but, those trials were ongoing when I was a fellow. I came out in 2004, but the point is that, if you look at the walk distances of Contact, Miracle, and other ones around that time, you saw about a 20 to 40 meter improvement in walk distance with the CRT population. And so at least you're in the ballpark, right? If not maybe a little bit numerically more than here, Contact or Miracle. But again, you're at least in the same ballpark, which is nice. Similarly with quality of life, and this is Minnesota living with heart failure, so the more negative, the better. You see what you see is an improvement from Barostim over control, but also what I think is more important is that even at 24 months, we see sustained improvement in Minnesota living with heart failure. And again, meaningful is about 5 points, and we're hitting essentially around 20. And again, if you look at the inset there with the CRT trials, you're looking at around maybe 10 points of improvement of quality of life. So numerically better, probably. But again, at least you're in the ballpark, which I think is important. If you unpack this a little bit further, a little deeper dive, if you look at the quality of life domains, why are people feeling better, right? Well, from an overall physical perspective, those domains, you see that patients are better. You can see with the various things that they're able to do, walking around the house and what have you. And then the overall emotional the living with heart failure domains, you can see are improved as well. And then EQ5D, this is a positive direction. We see improvements in mobility, self-care, et cetera. So again, I think that kind of unpacks as to what our patients are feeling with the device versus control. If you look at NYHA class, this is also something that is improved if you see compared to control, and it's sustained, at 24 months, and data is still, accruing and what have you. Again, the inset here, you can see contact CD and Miracle, 30%. So again, maybe numerically a bit better than our CRT trials per se, but again, we're at least in the same ballpark, which I think is fair. This is the reduction in all-cause death, LVAD or transplant. Again, it's kind of interesting here. I'll just kind of bring the p-value to your attention. This is, again, remember, this is done in the era of the pandemic, and so we had kind of a lot of trials that were affected by this, I think. But again, very nice and directional, very strong data. Safety is important, right? I mentioned it's extravascular, so that's nice. And we're not getting into a vascular space. We're making a pocket, and we'll again hear more about that. But again, for the major adverse neurologic and cardiac event space, 97% MANS-free rate. This is kind of a big eye chart here, essentially. But one nice thing is, again, we don't see a lot of safety issues with the device. So I'll bring a couple of new things that are going on right now. And, we have some acknowledgments here from people that helped. Look at heart failure hospitalizations. So the Hope for Heart Failure trial is one that we did earlier. I was involved with it when I was at Piedmont Healthcare, and we saw a reduction pre and post hospitalization, 6 months post of 6 months pre-implant, and then this is the one most recently post-COVID that showed a very similar reduction. So the next one I'm going to bring up is actually looking at post-hoc data from a ChargeMaster through Premier Healthcare, and we have patients from 2016 to 23, and you can see what we're looking at here: hospital visits, and then the like. 306 patients were found implanted with BAT in that data set. 66 years old, 25% female, 20% Black Americans, and you can see the follow-up periods and how many patient years were seen. So again, this is retrospective, but look at this here. It's very similar to what I showed you earlier. Okay, so you're looking at all-cause hospital visits and CV hospital visits and heart failure hospital visits. You can see a nice reduction pre versus post in terms of patient years. So again, it's got limitations. There's no doubt about that. It's lack of a control group, of course. There's lack of detail about what those patients look like with their heart failure severity. But again, you see that this might be directional at best. And of course, just like COVID-19 affected the trial, it may have affected something like a post hoc look at this stuff. So again, this is directional. It's, I think, important to know. And if you look at, again, sort of all these together side by side here, this is pre-specified, and then these were also directional. They're helpful to look at. Again, the smorgasbord here a little bit. Improved ejection fraction. Our colleagues at USC saw an improvement in ejection fraction. Our colleagues at Hanover as well saw the same. So really, again, this is what we see. Right. We see a reduction in a sympathetic parasympathetic, a rebalancing, I should say, of the sympathetic and parasympathetic systems, and an improvement in heart failure symptoms. Going back, here we are again. We're back to one of these original slides when we see, where CRT and BAT. Again, you're in the ballpark. This is important. Patients are feeling better, able to do more. So when you go back to this original slide, that sort of whole middle region is this unmet need. What do we do with these individuals? If we get patients titrated to what we think is a maximum, a maximum GDMT, you should consider after 3 to 6 months. After that point, let's move forward. What I don't want to see is patients kind of getting implanted, sort of down here or in the end stage. But again, after 3 to 6 months, this is important to probably think about as an adjunct, especially if the patients are symptomatic from a heart failure perspective, despite GDMT. So again, last slide here. What patients should be considered for Barostim? You can see it there on the left. I think the BNP, really, those numbers I think are important, only because I think that we want to be seeing these patients upstream, okay? And again, patients that are exercise limited despite GDMT, important. CRT non-responders, or exercise limited, et cetera, having symptoms of heart failure, important as well. Patients that are hospitalized. And, ask your patients these questions here, all these things. Some of us know what the METs are associated with showering, making the bed, et cetera. But if you can get this and ask these things, whether it's you or have a questionnaire for your MA to put in for your patients, I think that's helpful to know. Thank you.